to think about the future. I'm only Silvio Tatti, so nobody paid to me for this lecture, and you are going to ask for my talks. The future of colposcopy. You know, this is inequity of cervical cancer. I live in Argentina. You know, and then you can have this cancer in Africa and no cancer in Europe or North America. And this is vaccination. This is the true world in vaccination. In the US, the first dose only 54%, and in males, the first dose only 21%, but it's not in Australia, Canada, UK. HPV vaccination is more than 70%, and in the US, hepatitis B is more than 90%. So there is a lot of difference in between the world. But in ethnicity, Hispanic, white, and black. White Hispanic is more, 63%. Because Hispanic women have higher rate of HPV vaccination despite lower rate of health insurance compared with white women. Because Hispanic women have a lot of cervical cancer in the United States, and they understand what the importance of being vaccinated with HPV vaccines. But the good news are, among females aged 14 to 19 years, the HPV prevalence decreased for 11% in 5 years, to 5.1 in 2007 to 2010, and represent a decline of 56%. Within 4 years of vaccine introductions, the HPV prevalence decreased despite low vaccine uptake. Why we still need screening. Poor vaccination rates, existing vaccines do not cover all high-risk HPV types. Vaccines do not treat pre-existing HPV infections, and we still need 2 generations to eradicate, if this is the correct word, cervical cancer. But who we can eradicate cervical cancer? And then self-collection of vaginal specimen could be a good way to perform screening, because developing world, it means about 2,000 million women all over the world. But if you perform screening, you have another problem, where you have pathologists. And here's Africa. After IFCPC, we need to have a global vision. And then in Africa, you can see here that sometimes, Somalia, you don't have either one pathologist working there. So what we are going to perform vaginal samplings in Somalia if there is no pathologist to understand how it happened with the leads or something like that. Or if you can see either other countries as Central Africa. It's completely different than this as in the UK or the US. And you can see here the burden of disease in Latin America, where we have penile cancer, vulvar and vaginal cancer, anal cancer, oropharyngeal cancer, and cervical cancer each year. Every 80,000 new cases of cervical cancer in Latin America every year, and a lot of genital warts. And Spain, sorry about this, Xavier, but still we need about 50 years to eradicate cervical cancer in Spain, which is a high-income country, still today. The future of colposcopy. Which is the future of colposcopy? Vaccination against HPV 16 and 18 types, as well as the possible switch to HPV-based screening, is likely to change the profiles of women presenting in the colposcopic units. The sensitivity of colposcopy biopsy to detect precancer is about 70%, and for Mitchell, in a meta-analysis, high sensitivity of colposcopy is about 85%, but low specificity. Oh, not more than low, 70%. Which are the difficulties for future colposcopies? HPV vaccinations, launch of the non-covalent vaccines in the near future, we don't know, we would need to wait till December. HPV-based screening, and triage tests for HPV-based screening, and as P16 or methylation. So we can now analyze what's happened with colposcopy in recent years. This is a paper from Pretorius 10 years ago, And here you have a colposcopy direct biopsy for CIN2 plus, only 57%. But if you did the same year, the same paper, with different authors by Mario Sidori in Milano, which is a very well-trained colposcopy, the sensitivity is 90% and the specificity is 88%. Something happened in between these two papers in the US and in Milan, Italy. So, regarding skill, performing more biopsies increased the sensitivity of colposcopy, and this is a new paper from Pretorius in 2011. The objective is to review where to compare the sensitivity of CIN3 plus of colposcopy direct biopsy among practitioners, and to estimate the increase in yield of CIN3 per colposcopy when colposcopy direct biopsy is augmented by random biopsies. Our thoughts is they are still GPs. The paper never mentioned if they are OBGYN or if they work in a colposcopy clinic. We cannot know about the skill of these practitioners before the trial. Biopsies in this paper, biopsy were performed by bronchoscopic biopsy instruments that obtain only 2 millimeters squares of biopsies. So you can see here, this is the sensitivity of the physicians involved in this paper. You can see here the physician number 6 is only 28%, but very close, the physician number 5 is 92%. We cannot compare these two types of physicians performing colposcopy as a triage for a CIN3. There are several differences in between the colposcopists who perform biopsies in this trial. In the UK, there is a certificate to perform colposcopy in the lower genital tract clinics and audits. And in Argentina, where I live, there is a 2 years training and examination after if you want to be a certified colposcopist. This is completely different. So, if you cannot understand, this is a Tischler, this is a bronchoscopic biopsy, and this is a baby Tischler. One picture is more than 30 minutes lecture. Then you can understand how colposcopy was done. And this came from my friend Maggie Christian and the Tombola study. The follow-up of CIN2-3 detection after 3 years. Follow-up, no more than 3% to all the cases. Then, if you compare why is there such a difference in colposcopy reward, and we can compare the ALS trial and the Tombola trials and the performance of colposcopy in the US and the performance of colposcopy in the UK is completely different. Why? Here you have 72% for CIN2 plus found at the original colposcopy. But here in the UK, you can find 94% for CIN2 plus at the original colposcopy. And in the follow-up, there is a difference, 11%, 5%. So it seems that colposcopy works different in the US and the UK. The ALS trial is a big trial in the US, and the Tombola trial is a big trial in the UK. Maggie say colposcopy and biopsy is safe in the UK if the colposcopist is properly trained, if the service quality assured, if in your region colposcopy and biopsy is inferior to a blind 4-quadrant biopsy, examine while colposcopy and biopsy perform so poorly, rather than abandon a validated system of management. And the validated system of management of the patient is colposcopy. So let me talk about how colposcopy works in the developing world, and let me talk about the trial we perform in Sao Paulo, Campinas, Porto Alegre, and Buenos Aires. The name is LAMS trial. And there's the colposcopy performance in about 12,000 patients. This is the cutoff, CIN3, and sensitivity is about 90%, and specificity is 52%. But the cutoff, again, with all the system that you can screen and detect CIN3. And this is the PAP, conventional PAP. Sensitivity, 60%. The screening colposcopy, 90%. Hybrid capture, 96%. VIA, only 15%. So there is a huge difference in between the countries and how it works, the screening methods and the colposcopy. And it depends how the trained colposcopy is. And not at the end, but for the future, we have a new nomenclature in the United States, the Lower Genital Squamous Terminology Standardization Project, the last project. A unified histopathological nomenclature with a single set of diagnostic terms is recommended for all HPV-associated pre-invasive squamous lesions of the lower adult genital tract. So each patient sample is only a statistical representation of the patient's true biology. A sample from one area does not necessarily represent the most significant disease from Teresa Darack, and colposcopy is the gold standard? It's not the gold standard. There is significant variability in accuracy and sensitivity based on size, location, and physical characteristics of the lesions and the skills and experience of the colposcopists. I think this is the most important thing, the skills and experience of colposcopists. And biopsy is the gold standard? Not the gold standards. Significant variation in diagnosis based on terminology, use, and training. How you can see here, negative, low seal, high-grade seal, adenocarcinoma in situ, in a small area in the same cervix. We are going to perform the biopsy. So, if you perform a biopsy and you think that the biopsy is the gold standard, then you send the biopsy where? To the pathologist. And then, here, this amatoxylin-eosin morphology inter-observer agreement, if you have -20, there is a poor kappa index. And then the kappa values for benign lesions is 0.52. For CIN1, the kappa is 0.24. For CIN2, the kappa is 0.20. And for CIN3 plus, the kappa index is 0.61%. And this is very important, which is the quality of your pathologist where you work from or for. A suitable candidate biomarker we need. And then we have a suitable candidate biomarker as P16, which had a sensitivity of 88% for CIN2 in HPV-positive women in the Italian NTCC study in women in between 25 and 60 years old. A combined immunostain for P16 and Ki67 has a high sensitivity and specificity for CIN3 and could be considered as a triage for HPV testing. So, just now, Teresa Darack say, we have CIN2, but we have a poor agreement in the histopathological results. What we need immunostaining? Yes. So we have two different kinds of CIN2. So CIN2 positive is yes, really high-grade SIL. And if we have a P16 negative, we have a CIN1, which is really a low-grade SIL. And this is completely true, because now we can understand what we are talking about, the colpobiology. So there is no only histopathological results, it's how is inside the biopsy. So the future of colposcopy. The future of colposcopy has a central role in the management of patients with abnormal screening test. The IFCPC proposed a new terminology to classify colposcopic patterns and decide tailored treatments. Because now colposcopy is not a diagnostic tool, it's to produce tailored treatments in young women. So, why do we need a nomenclature of excision treatment types? To avoid using conization, cone biopsy, big loop excision, small loop excision, and to educate ourselves with the current understanding of how extensive an excision should be done. This is the really true of colposcopy just now, to join the treatment. So this is the T-zone 1 from Prendeville, 80% of all the cases, small resections, and you solve the problem. T-zone 2, endocervical canal, but you can see the lesion inside. And then the T-zone 3, which is a glandular disease, suspect microinvasion, or you cannot see where the lesion finished into the canal, and they need a suite or electrosurgical excision of the cervix. But this is the end? No. You always learn. And then we have high-resolution microendoscope. It's a novel cervical visualization techniques developed by Rebecca Richard Cottom and team at Rice University. No colposcopist, lab, or pathologists need. They use proflavine, topical contrast agent that stain nuclei in place of the cervix, a fiber optic proof as placed on the cervix, and fluorescence from the proflavine stain epithelium is transmitted back to this unit. The image is displayed on a computer screen in real time. And then you can see the nuclear size, calculate the nuclear cytoplasmatic ratio, nuclear crowding, and nuclear promorphism, and assess in vivo and in real time with the patient. And this is normal, and this is completely abnormal, scene 2, 3. And where you can see in your computer, in your tablet, or in your mobile. Okay? You cannot tweet. This is a pilot study, and here, this device, published recently, correctly classified all 12 scene 2 plus 100% as abnormal. So this could be one of the ways of the future of the triage of the patients. And the future of colposcopy, there is a prospect of proving the objectivity and performance of colposcopy with dynamic spectral imaging who assist the identification of high-grade CIN, but localizing and grading the severity of any cervical lesions. When this system was combined with conventional colposcopy, the sensitivity is 88% for high-grade SIL. And this is this system, and this is the website. In this study, the sensitivity of HPV-related 16 lesion is 88%. This author suggests that this way may have been due to more intense whitening. And then the future is colposcopy sent? No, we have the SET-CAN. And the SET-CAN is a new device produced by Sheffield University here in the UK, and the sensitivity is about 88%. And then you can see where to perform the biopsy with the SET-scan. Then you can see there is 3 steps: HPV triage, colposcopy training, and new technologies in the future of colposcopy. But either there is not the future of colposcopy for the TC zone of the cervix. We need to see the basic definition of the vulvar, vaginal, and anal and oral lesions. With colposcopy? Yes, with colposcopy. And this is, in the IFCPC classification, we need to understand dermatology. And this is the future. Because if the cervical cancer and CIN3 go down, the vulval lesions still go up. And the vaginal lesions and anal lesions still go up. So anal lesions in my clinic is 5% of all the patients who have a high-grade SIL or vulva, cervical, or vaginal lesions. It's really, as you can see here in a magnified anoscopy, as the CIN3. And we, as a gynecologist, can perform an anal colposcopy and perform a biopsy here and here, and this is a high-grade SIL. And this is a paper coming from India, and this is the dentistry. And what do you see here? You can see colposcopy in the oral mucosa related to HPV-16. You are going to use acetic acid? I don't know. You are going to use colposcope? I think you are going to use in the future colposcopy to make a diagnosis of this treatment and perform biopsies. So the current and future use of colposcopy, all women with abnormal screens may be investigated by colposcopy and treatment guided by colposcopy prior a punch biopsy that confirms a high-grade CIN. Over-treatment of CIN must be avoided, and there should be a suitable negative cytology or HPV status after treatment. The future of colposcopy at the end. Sufficient junior colposcopists must be trained and registered to sustain screening programs. Use of paper-based or electronic training logbooks could facilitate this process. Trainees may return home with their skills and disseminate their experience locally in the developing world. The adherence to agreed quality standards for best practice in colposcopy will help colposcopists to manage cases and perceive increased risk for cervical cancer and precancer in a standardized way. The Berlin 2011 consensus quality indicators, which is this one, are really very good to how to perform colposcopy, and that was published everywhere. But where is the focus and determination? Primary prevention by prophylactic vaccination, secondary prevention by screening with cytology, HPV test, colposcopy, and treated guiding by a colposcope and a colposcopist. And in real life, as Maggie said, as a diagnostic management tool, not only a diagnostic tool, in a devout or office practice by a trained colposcopist using a binocular colposcope, recording findings in a systematic way, auditing diagnostic performance, and also use the IFCPC classification. This is my thought. Thank you for listening.